Hello, this is a video journal for Unit 3. Wanted to narrate an experience with a new mom. She was on the maternity ward, had a 1-day-old baby girl, and was reporting, and a consult for psychiatric evaluation was placed for this patient because the patient was expressing suicidal ideations. Although the Columbia severity screening scale showed a rating of low risk, we did evaluate the patient, and the observations made during the evaluation sort of contributed to the safety plan and helped us understand that although the patient is at low risk, the patient does have a lot of protective factors and therefore should be able to cope with these suicidal thoughts. Patient does have a history of depression, which she says that she's never taken medications for. Her PCP had prescribed her a medication, the name of which she was unable to state at this time. She did not take those meds as prescribed because stating the reason that she did not like the way they made them feel. And that medication made her feel. So the patient truly did not receive any pharmacotherapy for her depression, and she did receive counseling once in the past for a couple months, and she said that yes, it helped her. Patient said that depressive bouts do come about intermittently, and she is able to sleep it off, quote unquote. So she typically sleeps and she feels better when she wakes up. That's what it means as per her. And so today she says that she, in addition to depression, she started to feel anxious quite late during her pregnancy, gestation, and she says that she did have this anxious spell during the labor and during the delivery. Baby was normal weight, no birth defects identified. It was a normal vaginal delivery. The patient did not have an extended labor. It was a few hours. The partner was bedside, extremely cooperative, helpful, was taking care of the baby, was very loving and affectionate towards the baby. So was the mother. The mother was pleasant. The patient she was pleasant, coherent, alert and oriented. She seemed to have an extended support system in terms of her family, who made of parents who live right next door from her. Patient has stable housing. She is employed and she is looking forward to returning to her job when she thinks that she's capable of. But first, her priority is taking care of the baby. And so all these things made us feel the patient at this time, we did suggest some Zoloft, but patient refused it. She was concerned about it showing up in her breast milk, although we did assuage those concerns. We'd explained that no, it's safe for the baby. But patient was okay with she was okay with seeking psychotherapy, so we did place a referral for her for psychotherapy. And the patient, her partner, her parents, they were all loving and caring towards each other and towards the baby, and they seemed like a collective unit, willing to take care of the mother and the baby. So with this, a safety plan was developed. Everybody was a willing participant to it. Her family, her parents, her partner, and the patient. And if any signs of suicidal ideation pop up in the future that are severe enough, they know that they're supposed to call the crisis line. So the experience made me understand that it's not just the Columbia Severity Rating Scale or what the patient is saying that we have to go by, but also observe all the other protective factors in her life and their influence on the patient, which also have to be taken in consideration to decide if the patient is able to cope with the situation and overcome it.